Welcome, everybody. We are letting everybody join right now. We're going to be starting our live stream series for the Frankel Cardiovascular Center talking about thoracic outlet syndrome. We already have Dr. Vemuri and Dr. Beaulieu on our video chat, which I will introduce shortly. And we are going to start sharing the screen. So again, tonight we are going to be discussing the venous thoracic outlet syndrome and touching on arterial and neurogenic. Again, we have our presenters here today. First, we're going to talk about Dr. Beaulieu, and Dr. Beaulieu is a faculty member at the Department of Surgery in the section of vascular surgery at Michigan Medicine. He treats patients at U of M as well as the VA. He graduated from Georgia Institute of Technology in 2007 with a Bachelor of Science in Biomedical Engineering, followed by his time at Emory University, where he graduated in 2011 with his medical degree, and then continued on to Johns Hopkins University, where he graduated in 2016 with his Master's of Science in Biomedical Engineering, followed by his general surgery residency and then his vascular surgery fellowship back at the University of Michigan. He has a lot of clinical specialties. His main clinical interest and expertise is very complex vascular pathology, including advanced techniques in the thoracic aorta, as well as pediatric complex vascular reconstruction. Along with him tonight is Dr. Vemuri. He is the associate professor in the section of vascular surgery. He is also the Handelman professor. He is the chair of the CVC Innovation Program, the Ambulatory Care Clinical Chief, and the vice chair of Business Intelligence for the Department of Surgery. He also had his time at Johns Hopkins University and graduated with his BA in 2000 and graduated with Phi Beta Kappa status. He received his medical degree from the University of Michigan in 2004 with AOA status. And then he went on to complete his general surgery training at U of M and his surgery fellowship at Washington University in St. Louis, and has been a board certified vascular surgeon since 2014. He also has a very complex patient care load that he has special interest in. He is trained in complex open and endovascular work in all the vascular beds, is specializing in arterial venous. Obviously, the main reason we have Dr. Vemuri and Dr. Beaulieu here today they are both experts in the thoracic outlet syndrome, which we are going to be discussing today. Before we get started, we just want to make sure that we know that there are no relevant financial relationships. So there's nothing to disclose for any of us here today. And you guys all know that you are here for a 1-hour CME certificate. You can log onto your account, and there's a QR code here, which you can complete at the end. This will be in the chat at the end of the presentation, but it is just up now if anybody wants to grab a quick picture, and then it'll be in the chat at the end. So again, before we get started, I'm just going to kind of quickly finish our introductions here, and then we will go from there. We're going to go over and I will introduce myself. I actually work with Dr. Vemuri and Dr. Beaulieu on a regular basis. I am a cardiovascular nurse practitioner in the vascular surgery department at Michigan Medicine. And again, I want to thank everybody for coming tonight and joining us this evening, and we hope you learned some valuable information. The objectives of this CME course tonight on thoracic outlet syndrome are we are going to describe and contrast the 3 types of thoracic outlet syndrome: arterial, venous, and neurogenic. We are going to utilize and understand the evidence-based approaches to thoracic outlet syndrome, understand and apply treatment options for venous thoracic outlet syndrome with venous thromboembolism, including catheter-based lytic therapy followed by short-interval thoracic outlet decompression. We're going to understand and apply treatment options for arterial thoracic outlet syndrome with subclavian aneurysms, including aneurysm exclusion and bypass. And then we'll be understanding the approaches for surgical management for neurogenic thoracic outlet syndrome. So a brief overview of how tonight is going to work is we are going to go through a presentation given by both of our panelists tonight. And then you can submit questions anytime throughout the presentation. And we will have a Q&A period at the end of today's presentation. Again, you can submit the questions while you are watching, and then they will be transferred over to us and we will review them at the end. So again, I want to thank all of our panelists for being here tonight. And then I want to thank everyone who has already joined for taking time out, again, out of your evening to be a part of this with us. With that in mind, I am going to pass this along to the doctors to start. And I believe Dr. Beaulieu, you are going to start.
Okay. Again, yeah, so I'm Robert Beaulieu. I'm one of the vascular surgeons here at the University of Michigan. We have Chandu Vemuri with us as well. He's going to be giving you a brief overview of some of the introduction concepts to thoracic outlet syndrome, as well as the neurogenic, and then I'll go in with both our arterial and venous. We're hoping to both give an overview of how the syndrome is diagnosed and treated. And we welcome any questions at the end, especially those that you feel can be nuanced or about the approaches. We're happy to answer whatever you got. Chandu, it's all you.
All right, thanks. Let's go ahead to the next one. So as Dr. Beaulieu mentioned and Gabrielle, we're going to talk some general points about neurogenic venous and arterial thoracic outlet syndrome and talk to you a little bit specifically about some highlights of our multidisciplinary program. Thoracic outlet syndrome is an interesting thing, particularly on the neurogenic side, because this is an old kind of fable where if a bunch of blind men were touching an elephant and they each touch a different part of the elephant, nobody would know that it's an elephant because they can't see it in its entirety. And that happens a lot with this diagnosis because there are a lot of things that cause neck pain, shoulder pain, arm pain, or symptoms in the upper extremity. And it can be difficult to ascertain what the true cause of that is unless you are able to grasp and kind of process the entire picture. Go ahead. This is a story I like to tell that I actually learned about maybe 10 or 15 years ago about a pitcher that was very famous in the 80s as one of the best pitchers in the Major League Baseball League at that time. His name was J.R. Richard, and he was going to practice and at games complaining of numbness in his fingers, mentioning little tiny blood spots that he was getting in his finger. And as he kind of kept talking about that, people kind of wrote him off saying that he was being lazy or kind of negotiate a contract or doing something that was inappropriate, but he kind of felt that something was not right. Go ahead. And then sometime in 1994, a newspaper reporter was walking under a bridge in Houston and saw him, and he was homeless and destitute. And what had happened is during a practice, he actually had collapsed on the field and had a stroke due to having arterial thoracic outlet syndrome, which typically causes embolism to the arm, but in him, it caused embolism retrograde up to his carotid. And so he actually recovered from that. That newspaper reporter contacted a neurologist, and he was able to get to rehab, stroke rehab, and ultimately wrote a book and went on a book tour, which I did not get to see. Was going to try and do it, but I didn't get to. But he actually recovered and is an advocate for the management and treatment of thoracic outlet syndrome. So it's just a short story showing how a rare condition can have a significant impact on an individual's well-being and quality of life. Go ahead. This is just a historical story. The first documented case of treatment for thoracic outlet syndrome it was in 1861, and it was a 26-year-old who was admitted to St. Bartholomew's Hospital with an ischemic left arm and underwent a cervical rib resection, which is actually similar to the baseball player story because both of those people had arterial thoracic outlet syndrome a couple hundred years apart. To go over some basic anatomy in this area, there are three spaces that we think about where you can get compression related to thoracic outlet syndrome. The left-hand panel of the image shows you those areas, the first one being the scalene triangle, the second one being the costoclavicular space, which is most relevant for venous thoracic outlet syndrome, and the last one being the subpectoralis space, which is most relevant for pec minor syndrome, which I'll mention now, but we probably won't touch on it too much unless you have specific questions related to that. On the right-hand side is a nice anatomic picture that we print and share with patients and find useful in discussion that's publicly available. And it shows you, the way I usually describe it is, this is how you are and your arm's coming out of the screen. And then you can see the clavicle and the first rib there. And between those two things is the thoracic outlet where the vein that drains blood from your hand to your heart has to pass. the artery that takes blood from your heart to your hand, and the nerves that let you feel and move your arm. And all of that has to not only pass between the clavicle and the first rib, but also your anterior and middle scalene muscles. And in about 30% of people, based on pathologic studies or studies in pathology, that space is, they're born with it narrow. And then in a significant number of other people, an injury happens or repetitive trauma happens that results in it becoming narrow over time. But this is the basic anatomy that most patients start with. The breakdown based on a high volume center is about 95% neurogenic. The next most common is venous, and the least common is arterial. In general, looking at data from a few years ago, about 5 or 10 years ago, about 2,500 rib resections are done. Most of them are neurogenic. Most of them are done by vascular surgeons, and most of them are done at teaching hospitals, being a rare condition. The reason most likely that they're mostly done by vascular surgeons is that most of the complications are vascular. And so we feel comfortable managing those infrequent issues. And it's an exposure that we use for other reasons. And so we have some familiarity in that space. This is kind of a slide, again, showing the same volume of that. We can move forward. And we'll go on to neurogenic specifically at this point. So neurogenic thoracic outlet syndrome, abbreviated NTOS, is an upper extremity symptom complex consistent with positional compression of the brachial plexus, which I tell patients is numbness and tingling in your pinky and ring finger with raised arm activity. It is what we call a diagnosis of exclusion, which means there's no test that can definitively prove that somebody has neurogenic thoracic outlet syndrome. But we go through an extensive discussion and workup with the patient to exclude competing diagnoses that could be treatable in causing the same symptoms. A persistent cervical rib, which is a focus a lot of times about thoracic outlet syndrome, is actually very uncommon in the general population. And it's a persistence of the C7 cervical rib, and it's associated with a small T1 nerve root. This shows the displaced anatomy that can create. In this picture, you see a completely formed cervical rib, which is attaching directly to the first rib. It doesn't always have to look like this. It can be an elongated transverse process, or it can be a partial rib where the rest of it is a fibrous attachment that then attaches to that first rib. So there are variations on this variation that can happen. This is an image, a picture. If you look on this X-ray and you look on the right-hand side in the top right area where above the clavicle, you see a structure kind of going up and down. The first rib itself is C-shaped. And then on top of that is a cervical rib attaching. It's not entirely obvious to see in a chest X-ray unless you're looking for it, but that's just an example of what one may look like. So some situations that we can result the pathophysiology that can cause neurogenic TOS is neck trauma, particularly with hyperextension. And that's hyperextension of the scalene muscle, which is typically motion in this direction or kind of back in that direction. Frequent repetitive stress injuries, which I'll talk about, can occur in both athletes and non-athletes. Occult first rib injuries. So there are people who may fall with an outstretched arm. There can be athletes that do sports where they feel a pain in this area, but it's not obvious that they have a first rib fracture. It's not easy to see on an X-ray, particularly if it's not displaced. And that can be an occult rib injury that happens. And as you get repetitive injury to the anterior scalene muscle, you can, and this is shown on histology from specimens that are removed at the time of surgery, a soft, pliable muscle can become fibrotic and spastic, and that can act as a focal point of compression. And again, most patients do not have cervical ribs, those who have neurogenic TOS. Now, there's this dispute in the community in general about true versus disputed TOS. And some practices or professions believe true TOS is only when you have an ENG abnormality in the ulnar nerve or C8 T1 nerve root distribution. We don't feel that way here. There are patients who have significant symptoms that are disabling to them and lower their quality of life without a competing diagnosis that have not progressed to the point of getting potentially irreversible nerve damage. In patients who have an EMG finding with sensory or delayed motor conductance, that may not be reversible at that point. It may be, but it may not be. So ideally, we like to find patients before that time point. The main symptoms are pain and numbness, particularly positional with overhead activity, numbness and tingling in the pinky and ring finger. But there are other things that can happen that are actually from TOS. In addition to controlling the muscles and sensation in the arm, there are autonomic nerves that control the blood vessels in the skin. And if those react inappropriately, it's called autonomic dysreflexia or autonomic dysfunction. And that can actually cause swelling because the veins dilate. or the arteries can spasm and cause a pale white or red arm. And that can also cause temperature changes. Patients may say that my arm feels really cool or cold, and that's actually due to that autonomic dysfunction there. You can develop over time. People will compensate, just like if you injure your shoulder, you may carry your body differently. And so without being able to use their arm, they often overcompensate with their trap muscles, and they'll get pain and tightness in their trap. And as that goes onto the back of their head, they can get tension headaches that kind of come around. Some people compensate with overactivity of their chest wall muscles or their scapular muscles or supra and infraspinatus muscles, and so they can get parascapular pain or anterior chest wall pain as well. Yeah, of the different things that we can do, and we'll show you some of the maneuvers, based on the Delphi consensus, when you look at what is most highly correlated with actually having the disease, not the DVU study, not the EMG, not MRIs, not CT scans, but tenderness in the supraclavicular area that reproduces the neurogenic symptoms is the most sensitive and specific finding. And then we'll show you the maneuvers about worsening with provocative maneuvers. Common things that are not TOS are competing diagnoses that are potentially treatable that can cause the same symptoms that should be evaluated for and excluded before coming to a diagnosis of TOS, and include carpal tunnel syndrome and ulnar nerve entrapment, both of which can be diagnosed based on history and with an EMG. Intrinsic shoulder pathology, which is very common. And sometimes what I have to discuss with patients specifically about shoulder injury is that if you have a shoulder injury and you don't need an operation for your shoulder injury, you still have a shoulder injury. And that shoulder injury could still be causing your symptoms, and it may not be fully recoverable. We may have to find a way with physical medicine rehab to find a way for you to manage your symptoms so you can go on with life and you regain some activity, but that doesn't necessarily mean it's TOS. And then cervical disc herniation. That's more common. It can be one-sided, just like with the lumbar spine, but typically it can cause bilateral symptoms. Neck trauma. And then to get to the diagnosis, we look for a history that's consistent, so maybe repetitive use or injuries. With symptoms of numbness and tingling in the pinky and ring finger with overhead activity, a physical exam that's suggestive of it, and the absence of competing diagnoses that can be treated. This can happen, I just mentioned this as a side point, that it can happen in athletes and non-athletes. A lot of secretarial work where people are sitting in a desk position, which also happens in people in the computer industry with poor ergonomic positioning, can provoke this. Manual laborers, people who work in factories, production lines. I had someone who put Hershey cans up, put the label on them. People working drill bits, people doing fine motion with their hands can get that, truck drivers and even surgeons. But in the athletes, it's a full range of athletes. Swimmers can get it, particularly those that do the butterfly, water polo rowers, baseball pitchers, and quarterbacks. They don't have a higher incidence, but it is possible for them to get it. These two things these two images depict the maneuvers that we do. The first test is called the East elevated arm stress test, 90 degrees here, 90 degrees here. Their hand is flat to the screen, and you ask them to open, close. You can do 1 minute if they're having really bad symptoms because you don't want to give them pain, or try to go all the way to 3 minutes. You're asking for symptoms of numbness and tingling and heaviness. You're looking to see if there's symmetry. They do it at the same time with both arms. Is there symmetry between both arms, and is there a change in color of the arm? So that's the elevated arm stress test, or the East test. The second test, which is also done at the same time, is called the upper limb tension test. They put both arms out, they tilt their wrist up and turn their head the other way. When they go this way, this stretches the brachial plexus. They should feel a sensation going down to their pinky and ring finger. Now, when they do that, if they feel pain on this side, that's actually more consistent with cervical spine disease. So you're looking for symptoms on the contralateral side. That's called the upper limb tension test, and it may be abbreviated in our notes as a ULTT. And this is for pec minor, to evaluate some for pec minor syndrome. And that is an issue where you kind of go down. So the humeral head is here, the clavicle's here. And if you push right in that space, right at that junction, you'll be on the coracoid process of the scapula where the pec minor inserts. If you push in there and patients get a radiating numbness and tingling down their arm, that is consistent with pec minor syndrome. If you have them push away against your hand, that activates the pec major muscle, which lifts your finger off of the pec minor and should relieve the symptoms. It's not fully diagnostic, but it's suggestive. Just a point of some other things that you can look for: cervical spine disease. The Sperling's test is when you push down this way, they feel pain on the same side. And MRI, and typically a neurosurgical or orthopedic surgery consult, is the best thing to fully evaluate that. In our program, we work a lot with physical medicine and rehab. They evaluate people with musculoskeletal findings and early non-operative cervical spine issues, including torticollis. And carpal tunnel syndrome, these are some of the distinguishing factors, but it's really the nerves and the fingers and distribution of the median nerve. You can tap on the nerve, reproduce the symptoms. Rotator cuff. The most common way I kind of tell patients about rotator cuff shoulder issues is if your pain is in your shoulder and it hurts when you move your shoulder, it's probably your shoulder. If you move your arm and your shoulder doesn't hurt, and you have something that starts here and comes out to your arm, it could be TOS. It could be cervical spine disease, but it could also be TOS. Okay. Headaches. With this, you can get tension headaches. As I mentioned, the trap muscle goes to the base of the skull. You can get tension headaches. It can cause frequent migraines, occipital neuralgia. And in some patients who have had a traumatic injury that may have precipitated their thoracic outlet syndrome, they can have a syndrome called complex regional pain syndrome, which being a chronic pain syndrome, when you look down the road at the pictures of outcomes, can decrease their chance of having a full resolution of their pain symptoms from it. And fibromyalgia and opioid hyperalgesia. The one thing I will say with fibromyalgia may be relatively obvious why that would make outcomes a little bit different. There was a time when people prescribed opioids for this. Opioids in some data has shown to actually cause a kind of a bad cycle where it accentuates or accelerates the pain, magnifies it. And in patients who are on opioids for musculoskeletal conditions that can't be treated definitively, coming off the opioids may actually lower their total level of pain. And that may be due to a misperception or miscommunication in their brain and processing of pain signals. And there are pain psychologists now that can offer alternative regimens to help those patients manage pain rather than being dependent upon or being on opioids. It's just a table summarizing the things that we mostly spoke about. And when we see patients in the clinic, we actually go through a large questionnaire, which sometimes, given the fact that their problem is their arms, they have to have someone complete for them. But the DASH is a disability of arm, shoulder, and hand. A score higher than 30 indicates some level of disability. We often operate in people whose scores may be as high as 70, 80, or 90. A brief pain index, pain rating scale, visual analog scale, overall pain intensity, pain catastrophizing scale. Higher numbers there correlate with poorer outcomes afterwards. Cervical brachial questionnaire, pain map and sensory disturbance, which is what you're seeing where they draw on it. A Zung self-depression or self-rating depression scale, which is actually very important because a depression can be a consequence of being young and disabled from neurogenic thoracic outlet syndrome, and then the SF-12. This is a picture showing, and we may talk about this a little later, but an ultrasound study that kind of looks at the area. This isn't for diagnostic purposes, but what we do is we allow patients to get a prognostic block, which is a 2% lidocaine injection into the anterior scalene muscle if we think they have thoracic outlet syndrome, or the pec minor for pec minor syndrome. If after that injection they have a significant or complete relief of symptoms, that is predictive that they're likely to have a good result of surgery, which would be 10% of patients having a complete response and resolution of their symptoms, and 90% having a significant relief or response from their symptoms. And so again, if a patient has a history and physical consistent with it, there are no other processes, their symptoms are severe, they've not improved with therapy, and they have a good response to the block, then we talk about surgery. We talked about physical therapy, a pain contract, and surgery for patients that don't get better. If you get better, that's fine. We're surgeons, but we don't need to operate on everybody. We'll go through two approaches. I'll show you an approach. Dr. Beaulieu and I have different approaches for this. I do a supraclavicular or paraclavicular approach, and then he does a transaxillary approach. I'll talk to you briefly about this. I make an incision above the clavicle or collarbone. I go through the platysma, and then we divide and remove the platysma muscle. We divide the platysma muscle, then we again go to the anterior scalene. We identify the phrenic nerve, which is the only nerve that runs lateral to medial in the body. We divide that muscle and we excise it in the majority of its entirety. We then go down to remove the omohyoid muscle, which is in panel B. Dividing that, you can see near that, in panel B is the anterior scalene, and as you get down to panel E is the middle scalene, and lateral to that is the long thoracic nerve, which we take care to identify and preserve. Once we've done all that, we look to divide the first rib and remove it as much as we can. Now, when we take out the first rib and we use a rib cutter, we typically get out about this much of the rib. But in addition to that, when I do it, I take out about 2 inches on either side through using a bone rongeur, which is what neurosurgeons use for things, to get a little bit more precise. You can see that in panel D. So what comes out and what the patient receives, because they all want the rib back, isn't the entirety of what was removed. It's the entirety of what was removed with the rib cutter. And complications that can happen, about 1 to 2% of patients can get non-life-threatening bleeding that may require a return to the operating room just so they don't have a hematoma there. 5% of patients in the reported literature can get a temporary phrenic nerve palsy, which can cause shortness of breath with a defect with a heavy activity, which typically resolves. A temporary scapular winging due to long thoracic nerve stretch, or less commonly plexus injuries. The most common thing that can happen with the plexus with that approach is the suprascapular nerve can be stretched, and that can cause some weakness with external rotation. Lymphatic leak happens 15% of the time, like in many neck operations on the left-hand side where the main thoracic duct often is. Out of about 300 cases, we've only had to do a secondary procedure one time, and that was for a angiographic embolization or lymphographic embolization of the duct. And then there's a question of persistent symptoms, which I mentioned. 10% of people get complete relief, 90% get significant relief. So some people can still have symptoms that last. And then at 2 years out from a lot of decompression surgeries that happen not just in this space, but can happen with other syndromes done in other professions like ulnar nerve release, you can develop scar tissues that seems for some reason to peak at about 2 years, and they can get recurrent symptoms. This is just a study out of in the JVS where we kind of published the change in patients' DASH scores, which is kind of one of the reasons we track them to make sure we're doing how we think we should do, and pre and post-op. And the breakdown between the gray and white is vascular versus non-vascular patients. Non-vascular patients being patients with neurogenic TOS, which due to it being a chronic pain syndrome may not have as big a difference between their pre and post scores, but still have a significant difference. And so summary before Dr. Beaulieu moves on to talk about arterial and venous is that some things, we have a lot of patience for these patients because they're often young and disabled and for no particular reason, so that can be hard for them. Typically takes about 4.6 years and multiple evaluations before they come to us. So we go into that expecting that. Doing a really focused history to tease out alternative explanations, doing the specific physical exam test, the EAST, the upper limb tension test, the palpation test, doing questionnaires, getting a good round of physical therapy, 4 to 6 weeks or more in to see if they can get relief without surgery, checking the block, and then moving on to surgery. And then lastly, we won't talk about it as much unless you bring it up later, but considering Pec minor syndrome. And I'll mute myself so he can go forward with the other two.
Awesome, thanks. So neurogenic thoracic outlet syndrome is certainly one of the more complex ones to diagnose. I think venous and arterial TOS lend themselves towards slightly more rapid diagnoses. So we'll talk about some of those diagnoses, perhaps some of the overlying syndromes that should be considered as well, and then the treatment. And within this section, we'll talk about the transaxillary approach as well. So the thought behind venous thoracic outlet syndrome is that there is a narrowing of the subclavian vein as it goes through the costoclavicular angle, so the angle between the first rib and the clavicle. And that repetitive trauma can ultimately result in both scarring on the outside and then scarring on the inside of the vein. And so that sets up sort of a system in which Virchow's triad can start, where you have stasis, you have endothelial injury, and then ultimately you develop a blood clot in your arm. It's also eponymously known as Paget-Schroeder's syndrome or effort-induced thrombosis. And so this is one of the more common ways that we see spontaneous or primary upper extremity DVTs, which are much rarer than lower extremity DVTs. When we're evaluating these patients in clinic, two of the things that Dr. Vemuri and I also ask about is if they've had a history of indwelling PICC line or central line in that area, as that would increase the risk and would be what's called a secondary upper extremity DVT, which is by and large much more common than primary upper extremity DVT. Family history or personal history of hypercoagulable disorders is also something that we bring up. Unfortunately, in the acute setting, an evaluation of a hypercoagulable panel is usually not very helpful because the patient's fibrolytic pathway will already be fired up. And so you're not likely to get accurate results in terms of what their factor levels are or what their D-dimer levels are. Interestingly, especially in some of my younger patients who have been referred for being members of team sports, and they notice that their arm starts to get swollen after they work out, and then they stop working out and their arm's not as swole. The young men are super happy their arm's swole, and then they're like, oh, wait, this is probably a problem. And they may have something called McCleary syndrome. And what that is that's intermittent arm swelling with use, but there's no evidence of DVT. As you can imagine, it's much more difficult to diagnose in these patients. And so you have to have a high index of clinical suspicion. It's still thought to be due to a compressive pathology, and it's thought that maybe the subclavian vein runs more anterior than in patients with venous thoracic outlet syndrome, thereby being much more closer to the costoclavicular ligament, which binds the first rib to the clavicle. What we'll typically see is that these are patients who do have either jobs or some sort of hobbies that rely on upper extremity overhead movements quite consistently. They may notice that they've had swelling for years, or as many of our patients who come into the emergency department, they have an acute onset DVT. And they have all of the things that you would think about with a normal DVT. They have upper extremity swelling, they can have skin discoloration, they may have pain with use or touch. Very rarely do they progress to phlegmasia, one of the reasons being that these patients often have a significant system of collateral pathways due to the progressive nature of the venous damage. And they sort of had the straw that broke the camel's back, so to speak, and they clawed it off. As with all upper extremity DVTs, for some reason, pulmonary embolism seems uncommon, though it's not something that I would say we never see. The physical exam itself is typically done geared more towards looking at the severity of the swelling. But when we're tuned into the risk of venous thoracic outlet syndrome, we do a physical exam very similar to the neurogenic thoracic outlet syndrome. And then we look for signs of venous hypertension on the arm. Things that we may see are discrepancies in the arm girth from the affected limb to the non-affected limb. It's not always reliable, but when there's extreme discrepancies, it is. Often patients, their dominant limb may be a little bit larger than their non-dominant limb to begin with, so you can't rely on just small discrepancies. Blue discoloration from venous congestion. And then often patients will describe a history of weeks of worsening collateralization across their chest, which is typically worse when exposed to heat. So a common story is that patients get out of the shower and they notice that one side of their chest, or for women, one breast actually has a significant collateral pathway that goes across it that they've pointed out to their spouse or their roommate for a couple weeks now. And then all of a sudden they develop this DVT. So sort of history element that's helpful in getting to the diagnosis. Testing is something that's sort of the paramount importance, not only because it can help you rapidly establish the diagnosis, but because some testing, including venography, can actually be the first line of treatment. So when patients come to the emergency department, which is one of the more typical ways that they'll come in with an acute upper extremity DVT, they'll often have undergone a CT scan for a pulmonary embolism, and you may see the first hints of clot in that. In our more chronic patients, we use CT venography and MR venography in order to be able to non-invasively see if we can diagnose the extent of the clot or presence of collateralization. In the acute setting, and we'll talk about this more in the treatment element of this, venography is also incredibly important in both restoring vein patency and helping to secure the diagnosis. You can see a representative venography here on the screen in which you have totally obstructed subclavian vein. Often the obstruction goes to the first major collateral because that'll provide your outflow. So you'll see a long segment obstruction that basically starts right at the costoclavicular angle right here. Not only will you see abrupt cessation of flow and some clot within the vein, which you can see by this white appearance within the venography here, but you'll see an extensive system of collaterals that fill more rapidly than the main vein if there is a open lumen here, and then empty often into the IJ or even directly into the innominate vein. Once you can either restore flow, or in patients who you're using this as a diagnostic method rather than to extract the DVT, once you return the arm to the abducted position, you should see return flow in a decreased collateral pattern, as you see from A going to B. With ultrasound or IVUS, which is depicted down there in C, you can also see damage to the lining of the wall as well. Typically, we do not need a duplex, though most patients get this. This does bring up a note about the use of physiologic tests such as upper extremity TOS vein studies or arterial studies. By and large, those have actually not been shown to be completely diagnostic for venous TOS or arterial TOS. Once you see a complete obstruction of flow with the arm in the up position, it can be suggestive of a tight thoracic outlet, but a significant portion of the population will actually have total obstruction of either their vein or artery when their hands above their head for a period of time. And as I said, hematologic testing at the time of presentation is not typically helpful. Another word on venography. We've moved to the practice of now starting to recommend early interventional radiology involvement with most of these patients. The biggest reason being that the earlier that we can establish flow back through that vein, either through the use of mechanical thrombectomy or pharmacomechanical thrombectomy, we found that this improves long-term patency after the first rib is removed, and it may reduce the risk of post-thrombotic syndrome. So a typical algorithm looks like this. A patient comes into the emergency department with an acute upper extremity DVT. If the symptoms are moderate or severe, they often get referred to interventional radiology for inpatient thrombolysis. It can either be with an indwelling catheter or a single session thrombolysis at the sort of decision of the performing provider. And then with that, you can not only get out the clot, you can actually see the point of compression, thereby diagnosing the venous TOS. There is some controversy whether balloon venoplasty performed at that initial time is of benefit or not. It does seem to symptomatically help patients who have residual clot after mechanical thrombectomy, but without first rib resection, which is kind of an ongoing theme you'll see here, its durability is severely limited and it does not improve long-term patency. In general, it's also recommended strongly that you avoid stenting patients who have not yet had their first or cervical rib removed if they present with venous TOS. The reason being what you see on the slide panel here over to the screen right. In A, you see a large collateral pattern filling around an occluded subclavian stent. When we zoom in on that stent, you can see it's occluded because there's a stent fracture at the level of the costoclavicular junction. And then once that stent was removed and the vein was reconstructed, we were able to restore patency. But that does significantly complicate how you repair this. And so not putting a stent in place is extremely important. Our treatment plan obviously begins with starting anticoagulation if there's a suspicion of DVT, imaging as we discussed with venography or duplex, and then surgical therapy most typically within 4 to 6 weeks. Without any surgical decompression, despite adequate results from a mechanical thrombectomy, 1/3 of the patients may recur, and this includes those that stay on anticoagulation. So I typically tell my patients that anticoagulation alone is not a protective strategy against venous TOS, and we need to remove the obstructing or sort of the compressing area, which we'll talk about in just a little bit. We usually allow a period of 4 to 6 weeks because we want that vein clot to stabilize before we significantly open that area. And depending on the approach, many people will pause the anticoagulation for a period of 1 to 5 days. And we don't want there to be a significant risk of worsening clot during that time period. The most common nationally surgical approach to venous thoracic outlet syndrome is the transaxillary first rib approach, which is the approach that I typically use. You can see on the left side of the screen an arm retractor called the McDor retractor, named after one of the early physicians responsible for diagnosing and treating venous thoracic outlet syndrome. On it, you can see an incision within the armpit. That's one that goes transverse between the latissimus dorsi and the pec major. We divide down to the subcutaneous tissue all the way down to the clavipectoral fascia, which we enter. You can tell that you're in it by the sudden presence of lymph nodes, every surgeon's worst enemy. And so then once you see these lymph nodes, you can actually carry out relatively blunt dissection down to the chest wall. You're going to continue your dissection on the chest wall until you get up to the first rib. There's a couple ways of identifying the first rib, and usually I employ 1 or 2 of these ways just to make sure. I typically find the subclavian vein first and trace that back as high as I can. There is a crossing vein that typically comes down to the chest wall, and that crossing vein usually immediately overlies the anterior scalene muscle. I'm looking for that anterior scalene muscle to make its attachment on the first rib, though it can make an attachment on the second rib. And so much of this also relies on trying to get your finger in there to make sure you don't feel another bony structure above that. I then make a high division on the anterior scalene after separating the anterior or the interosseous branches off the anterior portion of the first rib. And then we divide the middle scalene Most typically, especially in venous TOS, will remove the middle scalene quite close to its attachment on the rib in order to reduce injury to the long thoracic nerve, which may have 1, 2, or even 3 nerve roots in this area. In the operating room, and this is a thoracoscopic scope stuck in to evaluate this view. I wish it were this clear all the time, which unfortunately it is not. You can see that the anatomy is a little flipped than if you're looking at it from the supraclavicular approach. Towards the patient's back, you'll see the nerve root of T1 and C8. You also see the subclavian artery. And then immediately to the side of the subclavian artery, you'll see the anterior scalene, and on the other side of that will be the subclavian vein marked SCV here. Immediately next to the subclavian vein will be the subclavius muscle or the costoclavicular ligament within there. And that sort of marks the border of how anterior you need to get in order to successfully resect the rib and relieve compression. We also employ the paraclavicular approach here, and Dr. Vemuri and I have teamed up to do that on a few athletes. We feel that that's a better option for patients who need a patch venoplasty or a venous bypass because it allows for rapid exposure of both the axillary vein and the internal jugular vein to be able to perform that bypass, and is a little bit safer way to control the vein. We have toyed with and at times done immediate venoplasty at the time of rib resection, and in our more recent practice, we've moved a little bit away from that. We found that if you do venoplasty at the same time as your rib resection, you have to restart your anticoagulation much sooner, which can increase the risk of having a surgical site hematoma or hemopneumothorax. And so we are able to hold our anticoagulation a little bit longer if we haven't induced the endothelial injury with venoplasty. Some patients still require postoperative venoplasty, and in those patients, we'll typically get a duplex at 2 to 3 weeks following rib resection to be able to evaluate vein patency. There are many patients who have totally responded from their initial event, especially if they've undergone thrombolysis or presented quite quickly. And in those patients who have no residual DVT, they don't require any additional evaluation, and so we spare those patients any additional vein intervention. So patients who your venous TOS patients are those with upper extremity DVT. We treat them rapidly with anticoagulation and venography if acute, severe, and within 2 weeks. CT and MRV are our studies of choice if they're chronic. And then again, a point that is incredibly important is no stenting before surgical decompression. And the timeline of surgical decompression really needs to be talked about when the patient presents, because it's very difficult logistically to do a thrombolysis and then have the patient back within 2 to 3 weeks if you just send them out without a plan for when they're going to be back to the operating room. We'll talk about arterial TOS, which is thankfully the rarest TOS. It's also the most difficult to treat, in my opinion, and the one that puts patients at the highest risk. So the arterial TOS pathology is marked by the same compression, but one of the things that becomes most problematic and is one of the defining features of arterial TOS is that it results in an aneurysmal degeneration or an ulceration of the inner wall of the subclavian artery as it runs through this area, and that can harbor thrombus, which then embolizes down the arm. It's typically this embolization that's often the first presentation for symptoms or for patients. And unfortunately, it can be that they've been chronically embolizing to their fingers. And then when they take out their brachial artery or something large, that's the first time. And that really creates both an inflow and outflow obstruction that becomes quite difficult to treat. Here's a typical venography that we see. And in this one, you can see that this patient, as in labeled in A, has multiple occlusions to the digital arteries. That's blown up in B. You can see of the second and third digit, there's occlusions to the digital arteries. And then what brought them into the hospital was this occlusion of this brachial segment going into both the radial and ulnar arteries. In the left hand, just as a point of comparison, so you can see the patency of the digital arteries on that side. There is also a subclavian artery aneurysm associated with it. And this really corrugated pattern you can see with also sort of a shelf is quite typical of the subclavian aneurysms in there because of both septations and an irregular pattern of thrombus that develops within them. I wish I could claim credit for these awesome pictures, but these are all Chandu's pictures, and I think these are fantastic because they show patient presentation, which may seem subtle, but is quite common, that where they'll have distal emboli to their fingers. This is a patient that presents early, but then came in, or had this early, but then came in with a brachial thrombus, which he extracted. There was a cervical rib, and this fusion point between the cervical rib and the first rib is also quite common in patients who have a fully formed cervical rib. The pathway is not quite parallel, and so the path of the cervical rib often goes into the first rib, and it does so quite typically at the place where the subclavian artery comes through. Intraoperatively, you see this large subclavian artery aneurysm right here. There are, if you can imagine, when you do a carotid subclavian bypass, the limited view of the subclavian artery that you get by properly positioning the patient in the operating room, you actually get quite a good view of the proximal subclavian artery, which you can see here all the way back to going under where the anterior scalene would be. Within the plaque itself, there was an ulceration and an associated thrombus, and you can see this shelf, quite typical or quite similar to the one that we just saw. And then once it was reconstructed, as you can see right here, there's a very normal path to the subclavian artery through there. You'll see, as we talked about, patients who have some symptoms when they come in, but there's also a fair number of asymptomatic patients who just happen to be found to have an aneurysm. And then there's an even smaller subset of patients who present for neurogenic TOS and are subsequently found to have an arterial aneurysm. And those patients would be considered arterial TOS patients at this point. Digital ischemia is the primary thing that we're on the lookout for, but your imaging studies may also give you the hint of a cervical rib or aneurysm. And we do a CTA on all of these patients. There's an idea that you can often leave the subclavian artery alone. And so again, Dr. Vemuri helped to evaluate some of this and found that in patients with a large aneurysm or in whose subclavian artery was thrombosed or had a pseudoaneurysm, or those that had an ulcerated plaque, treating the subclavian artery at the time of first rib resection reduces the risk of subsequent repeat thrombosis events. And so in those patients, we'll do a reconstruction at the time of thrombectomy. And patients whose dilatation is less than twice the size of the normal artery, we'll leave their subclavian artery intact, remove the first rib and the obstructions that we've talked about, and then see if there's growth over time. So your history becomes much more important in patients with arterial TOS because you're looking for histories of small emboli prior to getting to the point of a large embolism. On your physical exam, you may feel this aneurysm in the supraclavicular space. You may also feel a cervical rib, though that's more rare. It's most typically seen on either your CT or your chest X-ray. And anticoagulation early, again, is an incredibly important part. These are the patients that Dr. Vemuri and I often do together because they're long days in the OR. It's a periclavicular incision. You're often doing a concomitant thrombectomy or a staged thrombectomy that you just did the day before, so the patient's on heparin. And so these are ones that it really helps to have somebody there who can, you can sort of think about the case with. Our surgical trainees, you know, I think that this exposure has become more and more rare. And so it's important for surgical trainees to get a sense of what's going on in that area, but it's not one that, especially our general surgery residents who may not have operated in that area, come in with a strong feeling of comfort with. And so it's also helpful to have two attendings in there. And I'll swing it back over to Chandu to sort of summarize a little bit about what our program here specifically at the University of Michigan Cardiovascular Center offers.
All right, thanks. Go ahead. I think there's a slide on that, right? So this is our general summary. So we talked about the three types: neurogenic, venous, and arterial. Neurogenic's the most common, exclude other competing diagnoses that could cause the same symptoms. We operate on patients with severe symptoms, who do not improve with the PT, who have a positive response to a prognostic block. With venous, the pathophysiology is repetitive mechanical compression leading to occlusion, venography and lysis, followed by anticoagulation and surgery at 4 to 6 weeks. And then for arterial, it's most commonly a bony abnormality like a cervical rib, leading to an arterial injury, which is a stenosis with ulceration or an aneurysm that leads to embolization. We do a CTA, anticoagulate, and then we go to surgery. We can kind of, in the interest of time, we've talked about a bunch of this, so we can move forward. So one of the things that, you know, that we both do together, Bobby and I, is we work with a lot of other surgeons, a lot of other people, actually, not just surgeons. We work with plastic surgery for peripheral nerve entrapment, specifically carpal tunnel release and ulnar nerve transposition. We work with neurosurgery for cervical spine disease. We work with PM&R for a whole range of patients that have musculoskeletal symptoms that we can't find a perfect cause for, that they are able to do a thorough evaluation and put them in a rehab program and or medical therapy that can actually get patients to a better functional state. We work with PT for thoracic outlet therapy. We work for OT, mostly for ergonomics. So for people that can get ergonomic benefit. Anesthesia for those patients who have autonomic dysreflexia or who may have facet joint disease that could benefit from epidural or paraspinal injections. Orthopedic surgery for primary shoulder pathologies, as well as Pec minor syndrome now. Dr. William A. Binder has joined orthopedic surgery and works with us on that as well. We work with psychiatry, not just for concomitant depression, but for those patients who have a abnormal or aberrant feedback loop for pain medications that have multiple pain generators that may benefit from pain psychology, which is relatively newer 5-10 year field, I would say, at least in our experience here, but with significant benefits to the patient. We work very closely with our interventional radiologists to take care of this. These are our personal phone numbers and our direct emails. If you need to get a hold of us, please feel free to text or call or send us an email. We'll do our best to get back to you in a timely way. We try our best to get the patients in within a relatively rapid fashion to be seen in the clinic by one of us or either of us. We discuss all the treatment options, including both surgical approaches, with every patient, and we offer them both and we let them decide, which one they want to do. When a venous or arterial reconstruction needs to be done, we typically do those together due to the complexity of the case. Thank you for your time, and I think we're both open for questions now.
Wow, that was a fabulous presentation. We really appreciate both of you guys going over all the 3 different types of thoracic outlet syndrome. I think everyone who is on here today has taken a lot of knowledge from you guys and appreciate all of your time. And I think you guys did a great job. So thank you to both Dr. Vemuri and Dr. Beaulieu for all of their time tonight. Next, we're going to go over to questions. So we have our first question is kind of a twofold question. If patients are being referred to the program for thoracic outlet syndrome, is there anything you guys recommend prior that they need? And then the second part of this question is if they have underlying issues such as carpal tunnel or shoulder, should they get that evaluated first? So twofold question to start.
I can start, and then Bobby, if you want to add in there. So for neurogenic, because it's a hard diagnosis, I think it's helpful to have a chest X-ray to look for a cervical rib and make sure there's no rib fracture. I think an EMG to exclude carpal tunnel syndrome and ulnar nerve entrapment is probably useful, and to establish a baseline. Beyond that, a cervical spine or MRI or shoulder imaging is probably very patient specific. And so if they have symptoms, I would recommend it, but you don't have to have that before they come in. What was the second part of that question, Gabrielle?
More just so they said, what is the priority? Like if someone has a shoulder or carpal tunnel, what to do first?
I personally recommend getting the other condition fixed first, because it can cause the same symptoms, and those things are much more common than thoracic outlet syndrome. But also, if you don't fix that, it's very hard to recover from thoracic outlet syndrome from that surgery. So I usually recommend that the other things are managed first. And then Bobby, you want to talk about venous and arterial?
Yeah, I absolutely recommend the same thing for our neurogenic patients. For our venous and arterial patients, typically they'll have had some cross-sectional imaging unless they do present with an upper extremity arterial thrombus as the primary symptom. For all our patients here that present with an upper extremity arterial thrombus of unknown etiology, it's pretty much routine now that we get CTAs, and so you'll see if there's an aneurysm or ulcerated plaque. One of the things that is probably less helpful are upper extremity physiologic studies like upper extremity duplex of the vein or artery, because in the absence of any symptoms, if a patient has an upper extremity study that shows there's compression of the vein or artery without any symptoms, typically those are not patients that would be offered treatment, and very likely that's a physiologic rather than a pathologic finding.
Perfect. Those are great responses. Another question came in about the scar tissue and the recurrence. If that does develop, do these patients have any kind of treatment options if their symptoms return?
Yeah, so they do. And the symptom recurrence is actually similar in both approaches. So it's about that 2-year mark for some reason in both the transaxillary and the supraclavicular approach. And the risk of recurrence is somewhat related to the length of rib that's left in place. Sometimes it's difficult to get the entire rib out in patients. We try our best, but when it's going to compromise their neurologic function because we're worried we're too close to the accessory nerves, we'll probably not take as much rib out. And we try to be pretty aggressive about it, though. For those patients, we actually start the workup again. So it's possible that patients who are in their 20s who get the first rib taken out and then go on and 5 years later report symptoms, they may have now developed carpal tunnel syndrome or cervical spine disease. So we start that workup again. We review with an EMG as well. And then should they still be found to have what appears to be a recurrent thoracic outlet syndrome, we can offer a repeat neurolysis or a repeat first rib resection. And most typically that'll be done through the supraclavicular approach, regardless of what their initial approach was.
Perfect. Another question we got is, can thoracic outlet syndrome get better on its own without treatment?
Yeah, so I can start with that one. So for neurogenic thoracic outlet syndrome, about 20% of patients can improve with physical therapy. And so, I think in that situation, that's why we start with physical therapy. So then you avoid those patients getting an operation. If you have venous thoracic outlet syndrome with a history of a DVT, as Bobby mentioned, about 30% of patients recur without surgery. So that's not one that you can kind of rehab through. Same thing for arterial. If there's a cervical rib causing arterial compromise, waiting on surgery is going to likely result in further embolic events.
Perfect. Well, that was actually our last question for the webinar. Again, I want to thank everyone tonight for taking time out of their busy schedule to listen to our experts speak. Again, I want to take time to say thank you to Dr. Vemuri and Dr. Beaulieu. Again, that was fabulous information. And I think everyone has learned so much about this topic tonight. We've achieved our objectives. In the chat, there should be the QR code for everyone to obtain their CME certificates. And I hope everyone has a great evening. And again, thank you guys so much for your time coming on and joining us this evening.
Thank you.